So it's a pleasure to welcome Mark Sujan for this seminar as part of Reason. So Mark is a chartered ergonomist. He manages his own company, Human Factors Everywhere. Mark is also a trustee of the Chartered Institute of Ergonomics and Human Factors, a visiting academic at the University of Oxford, and honorary associate professor at the University of Warwick. And the reason as to why I end up basically inviting Mark to this series of seminar as a speaker is that really I learned a lot about resilience from working with Mark, especially within the context of healthcare. And whenever I'm asked to talk about or give an example about resilience in complex environments, especially human resilience, I end up talking about one of the case studies that Mark wrote about. I don't know whether he's going to talk about it or not, but it is just Google the secret second handover, and you'll end up with a very, very interesting case study, which is now almost like a textbook example that I use. So highly recommended, unless Mark talks about it today. So, so Mark, we're all yours.
Right, thank you, Ibrahim. So the usual, let me share my screen thing. Right, okay, brilliant. Let's put that on full screen. Here we are. Okay, hello everyone, and thank you for inviting me. Just before I start, a brief acknowledgement of funding to the Assuring Autonomy International Program, with lots of thanks for funding over the past few years for this work. And so the topic of today is artificial intelligence and the human factors that go along with it, or that should go along with it. And if you've been following the news, which I assume most of you will be doing, at least in the autonomy space, you can see there is something about AI in healthcare literally every day. It's actually quite hard to keep up. And one thing that kind of strikes me is the political dimension to it. So, you know, in the UK, our Minister for Health and Social Care, Matt Hancock, is quite outspoken in terms of the role of technology and its potential to, I suppose, manage the challenges in healthcare, which we're facing not only during COVID, but also going further along. And he gave quite a well-noted speech last year, at the beginning of last year, where he says, actually, better technology is not just a nice to have in the NHS, it's absolutely vital. And so that was like aimed at people who were saying, we've got other problems to worry about, and AI isn't mature enough, and we need to sort out other things. He said, no, actually, we need to be right in there. We need to be world leaders. And, he kind of backed this by significant amounts of money, which were put on the table for the NHS AI Lab as well. And of course, from a human factors perspective, quite pleasing in a way is one line which he kind of sneaked in there, which is, the whole agenda is not about technology, it's about people. He paraphrases this quite frequently as a slogan, which is, giving clinicians back the gift of time. So letting technology take over administrative tasks, for example, so that clinicians can do what they want to do, what they were meant to do. And as I mentioned, he's quite an advocate for technology, and so he shared in an advert the apps which he's using, among which is Babylon, which you might have heard about. And it's a bit controversial because this advert was actually sponsored by Babylon, so there are quite close connections. But the reason I've got this up is because the Babylon Health Symptom Checker is one of these AI applications which have received a lot of interest and which have been in the news quite a lot, around which there has been a lot of controversy. And so I suppose you will have seen it, but if you haven't, so in essence, it's a chatbot which you can have on your phone as an app, and it asks you questions, a bit like Alexa, the Amazon smart speaker. And then you respond to it either by typing or speaking, and then it navigates through and then it doesn't actually diagnose you. It offers you information, which wasn't clear initially. And then the MHRA stepped in and said, actually, you cannot say that it diagnoses. You need to be quite clear. It's only for patient information. But it also does something else. It kind of logs the information which you provide, which means if you have a remote GP consultation, the GP can already see a summary. So that kind of is intended to save a bit of time. But as I was saying, these symptom checkers are quite controversial. There are studies which have questioned their utility. So for example, one study on the bottom right-hand side looked at the number of symptom checkers, and it found actually in many cases, within the top 3 diagnoses listed, the correct one was not included. And also the symptom checkers, one of their reason for existence is that patients can seek information about whether they need to seek urgent help. So whether they need to go to A&E, for example, or whether not. And so one of the aims is to keep people out of hospital. But what this study found is actually the symptom checkers are incredibly risk averse, which means, as soon as you say something like, having difficulty breathing or, anything remotely, linked to an emergent condition, it will immediately, by default, send you to A&E. So actually, it doesn't keep people out of hospital. However, that said, more recently, there was another study which actually found that the newer versions of the symptom checkers perform quite well. So they say, almost as well as GPs. However, there's, one thing to note about this study is it was not an independent study. So this was done by people who develop a symptom checker, whereas the bottom study was independent and was published in the BMJ. The other study was by a manufacturer, published in the BMJ Open. Not to say that BMJ Open isn't a reputable journal, but I think the risk of bias needs to be considered here. But, so patients and the public seem to like symptom checkers. I'm not sure whether, you feel the same, but there was a study and, that found that people quite enjoyed it and thought it was useful to them. Now, of course, we don't really know what being useful means, whether it changed behavior, that we don't know. It's just people found it useful to have access to medical information. Right? Okay, so this study here set in mammography is quite an interesting one, not just because it comes from Google Health, who are one of the key players, but also what they did was quite unusual. They used an algorithm which was trained on data from the UK and also tested its performance in the US, or on data which came from the US. And so that brings us a bit closer to real life, because what they found, there was a significant drop in performance when they moved from UK data to testing the algorithm with data from the US. And so I think that is really very important, because ultimately, these algorithms have an appeal worldwide. And so it's very important to understand and be transparent about what were the training data, where were they sourced from, and how will they translate, or how will they perform in contexts where they weren't trained on the patient data. And diagnostic apps are probably the most prevalent category. So this one here is skin vision detection of skin cancer. I used it myself, so you can actually see a little spot which I had on my arm. Two things to note here. First of all, you cannot just use the app. You have to consent that your information is being used for research purposes. As you can see there on the left-hand side, there's no option to back out of this or to opt out. If you want to use the app, you need to give up your data, basically, which is quite cheeky in a way. But the other thing which I found, that's just my personal impression, it's not scientifically based, but it claims, so it says, it says we have a large database of images of skin lesions, and the algorithm has been trained on that and makes its decision on that. But of course, it also asks you questions about your symptoms. And my feeling, only feeling, personal opinion, is it goes by your response to these questions more than by the image you send, because that little spot, if I say I have no symptoms, then it's low risk. The same image, if I say it's a bit itchy, suddenly it becomes medium or high risk. So I would like to know more, as a patient, as a researcher, I would like to know more about what is it actually that your algorithm is looking at? How does it arrive at its classification? And I'm sure people who are trained in data science and have a deeper grounding than me will be much more familiar with these kind of issues. Another project I'm involved with is the FAITH project. Quite interesting. It looks at using AI to pick up indicators of depression in cancer patients, so that clinicians can intervene or can provide treatment at an early stage, because depression is often quite late in terms of its diagnosis. And so what it does is you can talk to the app and it will listen to indicators in your voice, indicative of mood changes, for example. It also has surveys in there where you can record your dietary intake and other kind of things. And so it just tries to triangulate from these different information sources. It's a research project, so it's not really tried on people as yet, but over time, I think it's fair to say we will see across the board many more applications of this kind. Right, so I mentioned the NHS AI Lab, who are dishing out a lot of funding to promote AI technology and adoption in the NHS. And so on this one, we've mapped the most recent funding awards. I think about 42 applications were funded. And you can see it's mapped according to phase. So phase 1 is early stages, feasibility, more or less. And it goes through to phase 4 at the center of the screen, which is preclinical adoption. So they are actually now, within the research context, tested in a clinical environment. And two things to note, really. Unsurprisingly, the significant majority of applications are diagnostic applications. That is where AI is currently very strong. That is most likely because of the availability of data and the nature of the task, which is a classification task. And if you consider worldwide, I think we produce around 2 billion radiological images every year. That is, a treasure chest for algorithm developers, basically. And that is why we see so many applications there. The other thing to note is there are very few phase 4 applications at the moment. So the ones which are there are predominantly the more mature diagnostic ones, like the MIA mammography, for example, which is a mammography cancer, so breast cancer detection algorithm. Right, one application area where I'm quite interested in is actually the potential of artificial intelligence to address global health inequities. So, for example, if you consider, the development of AI costs a lot of money. The data usually then therefore comes from countries like the UK, who wants to be world leader. But the big problems are actually in the African region, for example, so in low resource countries. And if you consider, I think I read a statistic in Ghana, they have a total of 34 qualified radiologists, right? That's a tiny number for a large population. And so if AI could be used to enable clinicians who are not fully qualified radiologists to still make good decisions about, good diagnosis of radiological images, that could be a major step forward. Not without, of course, risks, but if you compare to the current situation, could still be quite useful. But there are lots of questions. As I was saying, one big question is, what about the data, which comes currently from wealthy countries? In African countries, for example, the data quality is also quite poor because electronic health records aren't necessarily as prevalent as they are here. And also, the infrastructure is quite different. So the context becomes even more important. If you consider only a third of hospitals have a reliable electricity supply. So what use are AI algorithms in a setting where your electricity cuts out all the time, or where they don't have powerful mainframe or desktop computers? They're relying on their mobile phones. So we need to think slightly differently about the context there. Right, so from my reading of the literature, what I found is pretty much all of the evaluation studies looked at AI compared to humans on fairly narrowly defined tasks. And so, for example, it always comes with a slogan such as AI outperforms doctors, or man against machine. And, so it's quite an established now method for evaluation of AI to run the AI over a set of diagnostic tasks, basically, and then have a small panel of clinicians, usually 2 to 5, who look at the same radiological images for argument's sake, and then to compare the performance pretty much out of the clinical environment and just on a very reductionist, lab-based task. And so there has been, again, this has been looked at, and so there has been quite an important study, again, published in the BMJ, where people then actually found, these claims that the AI outperforms humans are probably, well, not probably, are most likely overstated. And these studies are at high risk of bias because it's usually the technology developers who have done the evaluation. There are hardly any prospective evaluations. And so by and large, we are very much at the early stages, and we cannot really say much about the performance of this technology as far as patient outcomes are concerned. So we need to be quite careful here. And this is now where human factors and ergonomics basically comes in, because so ergonomics takes what is referred to as a systems perspective. So it puts people at the center, but it looks at the interaction of people with other elements of the work system. And it's quite useful to contrast the systems perspective with the current focus on the technology as reported in the evaluation studies. So for example, an evaluation study would look at the data, how data was sourced, how representative the data is, the algorithm accuracy, so whether it classifies breast cancer correctly, what the false positive rate is, and so on and so forth. The headline figures of humans versus the machine in terms of its performance. And then, of course, the discussion of algorithm bias, transferability from one data set to another one. And all of these are useful, no doubt. And it's not to suggest that people shouldn't be doing this, but it should be complemented or integrated into the wider systems focus, where you look at the interactions with people, where in terms of outcomes, you look at, does it actually make a difference to patient safety, to patient experience, to staff well-being, to staff burnout, these kind of things, staff fatigue? Does it actually impact on workload in a positive way? Does it improve situation awareness, or does it actually negatively affect these important indicators? And I talk about algorithm bias, but what about automation bias? Do people start to rely on technology blindly and unwarranted in a way? So I think it's very important to keep this broader system focus in mind, and that's what ergonomists basically bring to the table. And if you I'm going out of my area of comfort here, but if you look at the automotive domain, so Tesla with the by now infamous Autopilot is in the news, it seems like pretty much all the time. And at the Chartered Institute, our automotive sector group did a little report or a short report about one of the Tesla crashes. And what they found really is Tesla isn't helping the case by aggressively marketing the Autopilot kind of as, it frees you up from the chore of driving and almost insinuating you can, it's okay to look at your phone in a way. No, they're not saying that, but what the report found is it's implied in a way. And so we shouldn't be surprised if people look at their phone. And so, what the report was saying is it's actually not even adequate to talk about the driver was distracted, because you can only be distracted if you are focusing on a primary task. But apparently the people, who were involved in these crashes, or, who were asked, they didn't see driving as their primary task anymore when they were in autopilot mode. So they aren't actually distracted. They are not knowledgeable enough, maybe. And so they are misled in a way to believe the autopilot is something which it is not. So, and if you recall what I was saying earlier about Matt Hancock, who has a technology focus, saying the technology is about giving clinicians back the gift of time. Well, we'll have to see how that plays out. Whether what can happen is then clinicians come to rely on the AI doing the work for them. I think personally it's unlikely, but there will always be cases maybe when clinicians are busy and they come to rely on the AI and then something goes wrong because they over-relied on the promises which were made. And these things are really not new insights. So even back in the 1970s, 1980s, when automation started to be introduced in a very aggressive way in the cockpit, for example, or in process control rooms, already there people were saying, there are these ironies of automation where designers and developers of automation pretty much automate everything they can automate, but then leave the humans to kind of pick up pieces. And so they have a very disjointed task, and then they need to monitor the automated system, but they don't understand what's going on anymore. And I think it was Peter Hancock, an ergonomist, who said, if you only rarely require the human to intervene, they will only rarely intervene successfully then, because they're out of the loop. And as I was saying, that is stuff which has been around for 40 years, but seems people are still struggling with that. And it becomes, relevant again, even more so now with the influx of AI technology. So a useful system approach from an ergonomics perspective is this model, which is the SEEPS model, which stands for something like Systems Engineering Initiative for Patient Safety. And what is useful about the SEEPS model is to bear in mind, so we are looking really at the work system. And from an ergonomics perspective, of course, the people are at the center. And so what is important is, when we introduce AI or any other tool for that matter, we will change the interactions, and we will change the interactions with the person, the task will change, the organization around it might change, and all of these will have to be considered. So it is not just a narrow diagnostic task which we're looking at. The entire work system will most likely be affected, and I'll look at that in an example later. And on the outcome side, it is not just around the accuracy or the performance of the algorithm. No, I mean, there are patient outcomes we need to look at. There are staff outcomes, as I mentioned earlier, situation awareness, for example, fatigue, frustration, burnout. All of these are very important indicators. For example, when, this is not AI, but when electronic health records started to be introduced, frustration was through the roof because people just got fed up with all the admin work and the workarounds they had to do due to poor usability of the electronic health records. So, that systems perspective is very useful to understand and to analyze and to understand, what happens or what can happen when we start introducing AI into a clinical system. So this SEEPS model has been extended, and I think that is very useful in healthcare, probably also in other environments, I'm not quite sure, but in healthcare, this is very useful because as a patient, you don't just encounter one work environment. If we take the patient perspective, it is multiple encounters with different providers. So you will have your GP, you will have maybe the ambulance service, then you have the hospital. Within the hospital, you have different teams. You will have then social care, God knows what. So there are lots of encounters over time. And so, from personal experience, of someone who has to deal with cancer, for example, within the family, I can tell you over a couple of years, this can be a very stressful period where there's a lot of miscommunication and you get sent appointment letters from people who shouldn't really be seeing you because you were handed over, but they weren't told. Tests going missing, you need to chase them. And so the complexity of these interactions along the pathway is really what we need to capture. So, it's almost ridiculously reductionist to just say our AI classifies this mammogram without actually looking at the bigger picture, which is really what affects patient outcomes and staff perceptions. Right, so we, just moving onwards a bit, I'm just checking the time. So we try to, use this systems perspective in a couple of demonstrator projects, which are funded by the AIP program. And the first one was the SAM project, which has now concluded, which was undertaken with colleagues at the Royal Derby Hospital in intensive care. And so the aim there was to understand what would be the safety assurance requirements of using autonomous infusion pump in intensive care. And you can see in the bottom photograph a simulated patient. And on the left-hand side, just next to that big screen, is a stack of infusion pumps. And so if you are in intensive care, it is very likely that you will be on multiple infusions concurrently. And there have been, just moving on, there have been lots of studies which have shown that actually this is a high risk and highly error-prone activity. And so this particular study here was a meta-analysis, so it has looked across the literature and said actually intravenous infusions has about a 3/4 likelihood of making at least one error along the process. So that is incredibly error-prone, of course. And just recently, at the end of last year, there was from the Healthcare Safety Investigation Branch an investigation into the use of smart pumps, where doctors operating the smart pumps gave a bolus injection, i.e. the entire syringe, when actually it should have been done over a period of time. And so these are highly safety critical issues which can happen and which still happen, even though the smart pumps were introduced to mitigate against human errors in the setup and operation of intravenous infusion. So that is still around. And so we looked at what does the process really look like? What does work as done look like? And we used a specific method from the resilience engineering kind of theoretical background. So it's called functional resonance analysis method, FAM, in short, developed by Eric Hollnagel. And so what FAM tries to do is give a functional representation of what is going on. So represent work is done in terms of functions and their couplings or interconnectedness. And you can see that hexagon, which is the icon of FAM, basically. So every function is represented as a hexagon, and then it has these 6 aspects. And these aspects are used to give couplings between functions. So, the traditional coupling is the input-output relationship, but you can have other relationships, such as a precondition, for example, or one function might provide a resource to another function. And so the FAM process really relies on interviews, on observations with people to understand how is work actually done. And then it produces something really complicated to look at like this. So this is the FAM representation of the prescription and administration steps within the intravenous infusion management process. And so, it looks a bit complicated, but it's actually quite useful, because what it allows us is to, put work as done and the relationships between the different functions on a piece of paper or on a computer screen. And then when we start to think about, all right, we have now an autonomous infusion pump, rather than just saying, is it able to manage insulin, for example, autonomously? We can now ask, and if it does do that, what does it mean for the system? What are the open questions? What are the design considerations which we need to consider here, or which we need to take into account? And I'll just give a few as an example. So in terms of resilience, one thing which we found, which added resilience to the system, is occasionally, nurses would give an infusion without a prescription being in place. And that is, of course, a definite violation of protocol, because the protocol quite clearly says, doctor prescribes, nurse administers. And nurses should not really, in ideal context, administer medication which has not been prescribed. But so what we found in practice is there are lots of situations where this is actually very useful, where it adds resilience to the system. So, for example, the doctor and the nurse could be both hands-on on a patient who is currently in a critical condition, and then the doctor says verbally, and then, when we're done here, can you please start these infusions, and I'll write it up later. And so, it reduces the delay. The nurse can then straight away go get everything prepared, set up the infusion while the doctor is still busy. Nurse can get it started, and then the doctor at some point later, of course, you can see the risk, they might not, but at some point later will write the prescription. Okay, so it instills the ability to anticipate the prescription. Or equally, what can happen is a nurse looks at the patient. So an intensive care nurse spends a lot of time with the patient, pretty much non-stop. And so they know the patient really well. They can see if they're deteriorating. So the nurse might go and seek the doctor and say, I'm a bit worried about this patient. I think, shall we do something? And has a discussion with the doctor, and the doctor says, yeah, okay, start whatever kind of infusion, and I'll write it up later. And again, so it's kind of the nurse prompting the doctor responding, and the nurse setting up the infusion, even though there's no prescription in place at this point in time. So the design question is, what happens with the autonomous infusion pump? The autonomous infusion pump will only work if there's a prescription in place. So what does that mean for the resilience of the system now? So does that mean we force people to work as per protocol, which before they didn't do for good reasons? Or do we design flexibility into the system? Do we enable the autonomous infusion pump to accept, what I called ghost prescriptions here, which are non-existent prescriptions which will be inserted in the system later? Because the autonomous infusion pump needs the prescription in a way to do all the safety checks, right? If it's not in the electronic health record, the infusion pump has no mechanism for validating, is it the right patient? Is it the right drug? Is it the right concentration for the drug? And so on and so forth. Anyway, so that is one consideration. I actually want to look at the others now, but you can get the point. Mapping out work is done, the complexity of work is done, the variability in the system allows us to consider what will happen to that variability when we introduce technology, do we support it? Do we constrain it? What are we going to do? Either way, you can take a conscious decision here, right? And that is very important. Right, I'm moving on to the second project, which is currently still ongoing, which is the ASSIST project. And that is a project with a Danish technology developer, Quarty, and the Welsh Ambulance Service. The idea here is to introduce artificial intelligence into the ambulance call center to support the call handlers in recognizing and diagnosing quickly critical conditions such as cardiac arrest, because studies have shown, well, first of all, this is really time critical. You know, the sooner you, every minute of delay lowers your chances of survival by, I think, 10% or so. And so studies have shown that actually AI has the potential to speed up the process and also to speed up or to increase accuracy. And just to give you an illustration what it looks like, I've got a 1 minute illustration here how the AI works. So you can have a look here at the events timeline as you listen to what's going on. Just to be mindful, this is a training call, so no one is actually in actual distress here.
Fire and medical and the address of the problem?
1818 Bigelow Avenue North.
Okay, in 1818 Bigelow Avenue North, apartment 202?
Yep.
What's going on there?
My dad's either having a heart attack or a stroke or cardiac arrest. I'm not sure.
What's going on? Is he conscious and awake?
No. I mean, he's breathing, I think, but he's on the floor. And
okay, I want you to go look at him and see for sure if he's breathing, okay? And I'll stay on the phone with you.
He's breathing. My husband
okay.
says he's breathing, but he's laboring.
Is labored breathing? Is he responding to you at all?
No.
Okay. Does he have a history of cardiac problems?
No.
Okay. I got some help coming. Hang on the phone with me here. So if before the firefighters get there, if he stops breathing or it gets really slow, I want you to call me back and we're going to start chest compression CPR, okay?
Okay.
Just keep an eye on him. Okay.
Okay.
And I want you to look at it one more time before I get off the phone here. He is breathing normally for sure. Is that correct?
I mean, there's blood coming from his mouth. He's bit his lip or his tongue.
Is that him in the background?
Yes.
Okay. So, like I said, call us back if anything changes. They should be there in just a few minutes, okay?
Okay.
Okay, we're on the way. Bye-bye.
Here now.
Not if he's doing that, moving around at all. Is his arms moving around and making noise?
His arms aren't... No, he didn't.
That's him?
Yes, that's him laboring, yes.
That's him labored breathing?
Yes.
Okay, let's start CPR on him.
Right, so I mean, you can see how this works. So the AI listens in on the call, what is being said. It kind of provides a running record, basically, of what it identified here. And you could see early on, it popped up a kind of indication, possible critical illness. And then at some point, when it heard the labored breathing, it became more convinced that this is a cardiac arrest and CPR needs to be started. And this is actually also what the call taker kind of did. Initially, they said, call us back if it gets worse, but then they were listening into that kind of so-called agonal breathing, and they became increasingly convinced too that this is a cardiac arrest. And so the challenges, however, still are, how would we integrate this system into the ambulance service call center? And again, I bring up this image here to give you the system's perspective. This is not just about, does it identify cardiac arrest correctly? Does it have a high false positive rate or a low false positive rate? There's also stuff around, the impact on the workload, for example, the impact on the experience of the call handler, whether it interferes in any way, and so on and so forth. And that links, of course, or is affected by these interactions here. So for example, what's the coverage of the AI? Is it only cardiac arrest, or will there be lots of different conditions? Will there be different applications running for every condition? So, will there be interactions between the QWERTY cardiac arrest tool and another tool recognizing something different? What's the scope of the AI? Is it only to provide advice to the call takers? Or you saw that running kind of record keeping, that could be very useful for auditing purposes. So will it be used for auditing and training purposes? What about paramedics? Paramedics might want to see what's been going on, to have a further explanation of what's going on. So these are all things which are not decided, not determined. How is it going to interact? Is quite important to understand. I mean, it could politely pop up a running commentary, as it has done, or it could be much more forceful, saying this is a cardiac arrest, stop messing about. We don't know who has final authority. I mean, the AI, as soon as it recognizes cardiac arrest, could actually say, I'm going to send an ambulance now, right? Whereas the call taker might want to double check, ask further questions. So there are lots of things, skills and competence, of course, and the training. Do people need to know anything about how the AI works? My favorite example is Amazon Alexa. I'm kind of obsessed with it and how bad it is, really. So over time, I've come to learn not to ask it certain questions, because it will just never get it and you waste your time. And so, and this is a safety critical environment, do the call takers need to know how the AI works, how it makes its decisions, or is it sufficient to just say, here's a new tool, this is how you interact with it? Or does it have to be deeper? Anyway, so I've been doing this time not a FAM analysis, because it's a bit more bounded here. So I've been doing what is called a cognitive task analysis, where I look at what are the cognitive activities here in recognizing things like out of hospital cardiac arrest when someone calls you. And the activities are actually fairly standardized. And you could see that even though it was an American context, they were doing the same thing. So first of all, you establish the address and the contact details, because you need to know where to send the ambulance. Then you ask triaging questions. Is the patient conscious? Are they breathing? These are the two critical things. If the answer is no to both, you need to send an ambulance straight away. Then they have a number of set protocols. And depending on that protocol, you will have to ask specific questions from which you are not to deviate. And then you need to give instructions like CPR, for example. Okay. And so for each of these steps, I asked people, what makes it difficult and how do you deal with it? What are the cognitive strategies here? And I just want to, for lack of time now, focus on asking the triaging questions. Is the patient breathing? Are they conscious? Which are really critical. And, they were saying things like, sometimes the caller is in a panic and they can't say anything, but they just scream at you. Or they are in a panic and they will blurt out 25 different symptoms. And then you need to listen in carefully and pick out the critical symptoms. Sometimes it's the patient themselves. They might have had a stroke. You can't understand them because they've got slurred speech or are hardly able to speak. Sometimes, they are intoxicated on drugs maybe, or, have had too much alcohol. And so again, you can't understand what they're saying. The line might be poor. They might be calling from a very poor mobile phone reception. But then also what I found really interesting is sometimes the caller doesn't want to tell you because they don't want to admit to themselves that their relative or their friend or whoever is in a critical condition. And so you ask them, are they conscious, are they breathing? And they will say, I think so, yes, I think, which means more, I hope so, but it doesn't actually mean they are. And so it requires a lot of skill to get that critical information out of the caller. And that of course is then the challenge to technology developers. I think from a systems perspective, I would like to know a lot more about how the technology deals with these kind of things and how it interacts with the call handler. The call handler often then asks further questions. Terminology is another one. So, you ask them, are they breathing? And then, the answer is not yes or no in the way you would like it. They might be saying, oh yeah, they're making funny noises. Well, what is a funny noise? What does that mean? And so the call handler will give synonyms and will say, are they gulping like a fish for air or something? And so they can translate these synonyms then into the criticality categories. And so these are all things which we need to consider, I think, when we start thinking about either replacing people with technology or augmenting what people do with technology. But I think that is very important. So that's why we did this cognitive task analysis. And I need to move on a bit. And so, you can use this information to map it onto your design. So here, what we have is we've got the so-called levels of automation, which you will know, for example, from the automotive domain, which ranges from no automation to full automation, in our case, autonomy, I should say. And it's mapped across the stages of human information processing. So information acquisition, information analysis, decision-making, and action implementation. And so currently, everything is done with human autonomy. So the call handler asks about the symptoms, they prioritize the symptoms, they select the call priority, and then they send it over to the dispatcher. Futuristic, but probably unlikely, is you have an AI chatbot, as the symptom checker, for example. They prioritize what goes on, they select priority, and they automatically dispatch the ambulance. But actually, and why this is quite useful is the more realistic scenario is that we jump between these different levels of autonomy. So for example, it could be that the call handler has the responsibility for leading the call. And so they ask questions and the AI only listens in and records it. But based on the information which the call handler was able to elicit, the AI then prioritizes, okay, and for example, highlights, okay, cardiac arrest. But it only suggests a priority, and the responsibility then still lies with the call handler. But once it's recorded, then the AI takes over and actually dispatches the ambulance. We don't need to go through a dispatcher. And we need to think about the implications, of course, of different design options. I'm not saying this is the ideal thing. All I'm saying is all this information which we have now gathered can help us as designers to think about the implications of integrating AI into a clinical system. And I'll skip that slide now, just move now to the conclusion here. So, I mean, what I've kind of tried to communicate to technology developers, to regulators, to policymakers, actually, is that it's not about the technology, as Matt Hancock was saying. It's about how we integrate AI as part of the clinical system. An autonomous system will not be fully autonomous. It will be a team player. So it will be the AI clinician, basically, but like any other clinician, it needs to work with human clinicians and other machine clinicians, maybe. And that means these kind of ironies of automation, which we can now call ironies of autonomy, still remain highly relevant and need to be considered. And of course, so what I advocate is human factors and ergonomics as a systems-based discipline, which can help us in understanding work is done and guide the design and evaluation of AI. Right, so I've left a bit of time at least for discussion. Thank you.
Thanks a lot, Mark. So I'll open the floor, as it were, to any of the questions from colleagues. Anyone wanting to start?
I have a question, if I may, Ibrahim.
Yes, you're second. First, we have you and Danny from California.
Thanks, Ibrahim. Excellent talk, Mark. I just have one thing occurred to me when I was listening to your notion of ghost prescriptions. It's very similar to what happens in agile software engineering methodologies. Often developers, they love to work according to the tickets that are in Jira, but sometimes they spot something on the fly, and so what they'll then do is they will, according to their best practices, will then create a sort of Jira ticket after the fact and document exactly the justifications for why they're doing it. They might do this after they've actually done the fix, but still they like to record this Jira and stick it in the system as sort of post facto kind of documentation, justification, just like your ghost prescription.
Yeah, no, indeed. I mean, I think you can find resilience, in every work context. But I mean, the real challenge is to be transparent about this. Often, and it's often called workarounds. So often it has a negative connotation, and so I think we need to be realistic around, that notion of workarounds. They are what creates the resilience, but can sometimes, of course, also lead to failures.
Right. Yeah. Thanks.
Thanks, you and Colin.
Thanks, Mark. And a number of really interesting things. You talked about the difficulty in these claims that are often made about better than human. Couldn't agree more. However, what strikes me is we have very, very complex systems. I consider something like the NHS, and as soon as we put any technology into place, not necessarily autonomy, the people change their behaviours around them. The government looks to reorganise the organisation to maximise their usage of resources and whatever. So how should we realistically measure performance of a technology that is going to have such wide-ranging impacts?
Well, I mean, that question is, of course, spot on. So, I mean, in a healthcare environment, what you have, of course, as the gold standard are clinical trials. And these are prospective and controlled evaluation studies. Now, of course, they have been criticized for also being quite reductionist. But what we have, for about, I think, 10, 15 years is the evaluation of complex interventions, because a clinical trial was initially developed for different types of treatments or different types of drugs. But increasingly, people have started to realize actually often we are introducing what is referred to as health technologies. And so, the framework there could be called realist in a way, which means first of all, the technology developer or the developer of the intervention needs to articulate a theory of how they believe the intervention will actually work. And that needs to be made explicit. And then you undertake prospective studies and you have a look not just at the outcomes, because if you only look at the outcomes, what you will see is probably an averaging effect. So yeah, in some situations it works, in others it didn't. And so you really need to see the mechanisms behind the intervention. In which contexts were the mechanisms successfully triggered? In which context didn't the mechanisms work? And so the answer will probably be, it works for some people in some contexts. And that's what you want to understand.
That's great. Thanks, Mark.
Radu?
So maybe to carry on from Colin's question, you suggested possibly clinical trials, Mark. Do you think the same methodology would be applicable if such technologies would be evaluated through clinical trials, or do we need different methodology?
Yeah, so I'm of course not a clinical trial specialist, so I have to kind of bound that a bit. There are people whose bread and butter is to design clinical trials, but no, clinical trials have been quite responsive to, as I was saying, health technologies, and we have now different types of clinical trials like step wedge trials and so on and so forth. And one of the colleagues at Oxford, for example, a PhD student, is involved in an initiative to promote, for example, reporting guidelines for preclinical evaluation of AI technologies. And I think we are seeing now more and more of these efforts being stepped up, and they all advocate a broader evaluation than just looking at the algorithmic performance. And I think clinical trials ultimately will have a role to play, but they won't be the standard randomized controlled trials. There will be more recent modified trials. But as I was saying, I'm not an expert on the trial methodology, even though I'm sometimes involved in some, but I'm not the methodologist there.
Thank you, Mark. So maybe I'll have another short question, sort of orthogonal to the actual discussion. You mentioned that there is now a treasure chest, I believe, of data sets that researchers could exploit. Is there a way that you advise maybe a PhD student to approach these data sets and access them? Or what's the process?
Yeah, so I mean, there's like an unofficial treasure chest as well as an official one. So the unofficial is there's just a lot of radiological data going around. And so, you know, that data can be made available, I suppose, if you work with hospitals and other healthcare providers. But that said, there are initiatives to create national databases. And for example, during COVID, which we are still during COVID, but in the earlier stages, NHS X, for example, set up the National Chest X-ray database, specifically for that purpose, to enable algorithms developed all over the world to be tested, to be validated on UK population data. And that data is available. So, you know, you could get in touch with NHSX, but it is chest X-rays only, you know, specifically also for the purpose of helping with COVID decision-making.
Thank you.
I'm aware of time, but Tim Coffey sent me very good questions on the chat. I don't know whether you'll have time to respond to all of these, because I'm aware you have time constraints, Mark. You have to leave in 3 minutes.
Yeah, I mean, if we just take the first one, so the training, I think that is a really important thing. And so I mean, I did some interviews with healthcare professionals, and so yeah, I think everybody I talked to was very optimistic about the use of AI, but equally they were a bit disconcerted, and they were saying things like, you know, if it were another human, then I would trust them based on my knowledge of them. So for example, if it's a colleague I've worked with for many years, then I would implicitly trust them. If it's a novice, I would keep a closer eye on them and just ensure that, you know, they do what I would do. And so they were saying, I would want to know how the AI works, whether it looks at the same things I would look at. And I think that's really important. So we need to, you know, I mean, explainability has been such a buzzword, but we need to explain to a certain extent to people, first of all, how the AI arrives at its decisions, where that decision-making differs from human decision-making, or if it's actually the same. But then also they were saying, you need to show me what good and bad looks like. You know, I don't know how to spot bad AI decision-making. And so, you know, now you're putting me in charge, basically. You're saying you've got 10 infusion pumps, all autonomous, doing their own thing. You know, keep an eye on them. But what does keeping an eye on them actually mean? What does good and bad in that respect look like? And that is not just an issue of training, it's also an issue of interaction. So, for example, the AI, should it communicate uncertainty to the decision maker or not? So, for example, in the call handler example, you could see it did two things. So it had, like, you know, potential critical event and then cardiac arrest detected. So it kind of graded it along 2 dimensions. But even when it says cardiac arrest detected, it probably is only 90% certain, or sometimes 99% certain. So the question is, should it communicate this uncertainty in some way? In the autonomous infusion pump example, it's even more tricky because it can vary quite quickly, and it's a process over time. And so should the AI have the ability to project into the future and say, if things stay as they are, in about 10 minutes, I might not be able to control the patient's blood sugar levels with the insulin currently. Should it at this point alert the nurse, or should it wait another 5 minutes? Or should it wait until it cannot control the blood sugar levels anymore and then alert the nurse? But then it's probably too late. So that is a very tricky issue. And I will just finish on kind of coming back to Matt Hancock, who says, give clinicians back the gift of time so that they can care for patients. But the danger is actually nurses and doctors won't be caring for patients, they'll be caring for autonomous technology, which could be quite perverse, of course.
No, that's great. Okay, great. Thanks a lot, Mark, for this very important seminar, and thanks everyone for attending. And sorry for being late by one minute, but I wish you all a very good and nice afternoon. So see you in a couple of weeks.